Travis for this opportunity to talk on hitting the mark with MIGS. So this is a video-based deconstruction, and we also have a 4D training along with it. So thank you once again for this opportunity to the scientific committee team, and we'll be starting on time. So first, we have Dr. Amit Pandey, and I would like to extend my sincere thanks to the whole team, Dr. Vanitha ma'am, Dr. Moideen sir, Dr. Madhavi, Dr. Saiban, and Dr. Murli Ariga sir for consenting and being a part of this wonderful step-by-step video-based IC. And I would like to request Dr. Saiban also to join us on the dais. And we'll be taking you through a simple video-based practical tips, complication management, a simulative training module, what are the financial implications and insurance-related tips and tricks. We do have our hand notes uploaded as well. You can actually get our hand notes because this is the first time AOS has done an initiative of hand notes, and transformative guidance and cognitive coaching is also being done. So with that, we'll have MIGS, a paradigm shift in the world of glaucoma surgery by Dr. Amit, who is one of the persons who introduced me to the world of MIGS along with my good friend Saiban and Vanitha ma'am. So looking forward to the paradigm shift, Amit. Yeah.
Thank you, Prasanna, for making me part of this wonderful IC, and thank you, Dr. Aditya, for being our only audience. He is interested in the MIGS speaker who is about to come now. It's okay, thank you. Glaucoma, we know it's a big problem, the global impact it has, and blindness in glaucoma is very common. 4.5 million visually impaired, 3.2 million blind because of glaucoma, and 1/3 of those blind are in India. So 1.5 million people blind because of glaucoma in India, the biggest group of blind people. We are the blind capital of the world, and so there is something that is not going right with the current stepladder pattern that we follow in glaucoma management. Medications, majority of our patients are on medications, and once the patient comes into severe and advanced stage, only then we do a trab, and that fails we do a tube, and last we do a cyclodestruction. So that huge gap between medically managed people who are progressing in spite of their medications is something that we need to target, and that's where MIGS comes in. We know the problems with medical management, biggest problem being compliance issue. 40 to 60% of our patients don't adhere to their medications, ocular surface disorders, systemic side effects, poor quality of life because of multiple dosage every day, and dependence on their family members, and fluctuations in IOP is another problem. And these things can be solved by surgery, but till now, before the advent of MIGS, surgery, like I told, was limited to severe and refractory glaucomas because there are certain risks of these invasive surgeries, and that outweighs the benefits that we get in mild to moderate. So this huge gap is to be filled by minimally invasive glaucoma surgery. Minimally invasive glaucoma surgery, as we know, is it's a wide range of implants, devices, and techniques which utilizes small incisions. There's minimal trauma, quick recovery, and favorable risk profile. So you have so many now worldwide. Here in India, we have the iStent group, we have the trabectome limited amount, we have the KDB, GAT, suture GAT, we have the ECP also. The genesis of MIGS, it started with the development of devices. Basically, first, actually, if we consider ECP came the first, then came the trabectome, was the first device to get US FDA approval, and then came the iStent from Glaukos. 2004 trabectome, then the iStent. These are the milestones in journey of MIGS. 2015 KDB got so these devices are not very new. They're more than a decade old now, and worldwide there have been landmark studies on MIGS. there has been global acceptance of MIGS, spearheaded by the United States, uh, because of their early FDA approvals and extensive clinical research. Also, because of the comprehensive training programs that they have for surgeons and establishment of MIGS as a standard care of treatment in many institutions, also there. European countries followed suit, and they also have shown significant interest in MIGS, with many of them adopting it as soon as almost the US. The Asia Pacific region also, and other emerging markets also, the adoption of MIGS has been steadily increasing. Factors like improving healthcare standards, increasing awareness of glaucoma treatments, and of course the prevalence of glaucoma itself in these regions is the highest. Global acceptance, if you see the US trend, right now majority of the surgeries that have been done in the US for glaucoma is MIGS, and that level is almost 10 times that of trabeculectomy and glaucoma drainage implants. So efficacy, if you look into efficacy, there have been multiple studies. These are studies for the iStent group, randomized controlled trials, prospective case series, all showing good and sustained release for over 5 years. What more do we need? Efficacy, this was a recent meta-analysis of 1000 plus eyes for iStent devices, which is probably the biggest group in a study. Similarly for KDB, similarly for other MIGS devices also. I'm not saying only about the iStent, I'm talking about all MIGS. So we have multiple studies which prove their efficacy of these devices. Safety is the hallmark of MIGS, and the major complications that you can get is transient hyphema and some IOP spikes in these MIGS that we do here in India, which can be managed conservatively. Again, reoperation rates are very low, almost 5%, less than 5% in many cases. If we compare it with filtration surgery, the complication rates are significantly lower, the recovery time is much shorter, post-operative care is less intensive, timing of the intervention is, we can intervene much earlier in the disease, and that's the main focus. Like I told in the starting of the presentation, that majority of our patients, they get a surgery done only when they advance into a very severe stage. But with MIGS, we can intervene much earlier to prevent them from having advanced visual loss. Quality of life impact is much lower. So I'm not saying everything is absolutely fine with MIGS. There are limitations, mainly the efficacy in severe glaucomas and cost and availability issues. That's the limitation. So to conclude, MIGS has revolutionized glaucoma management by offering a combination of reduced invasiveness, effectiveness, and enhanced safety. And this represents a shift from traditional, more invasive surgeries, providing a balance between a conservative management like medication and extensive surgery. So this, despite their advantages, MIGS has certain challenges, including limited efficacy in severe glaucoma cases and the cost issue. But it has created a paradigm shift in the management of glaucoma worldwide, and it's being high time that we practice it in India. These are the references. Thank you.
Thank you, Amit, for this wonderful talk. I would like to have Vanitha ma'am's comment on MIGS, the way forward, as Dr. Madhavi is getting ready with the presentation.
Prasanna, but what I would say is that the bottom line is MIGS is here to stay. Whether it's costly, not costly, there are cost effective means, there are ways you can make it cost effective. Minimally invasive is the way forward in all of medicine, so why not glaucoma? We did shift to phaco, didn't we? We do femtolaser cataract, don't we? Why did that happen? That revolution was lacking in glaucoma. It has now started. Thanks.
Thank you, ma'am. Right, next we'll move to the ready to kickstart. So, for MIGS, we need to do a successful intraoperative gonioscopy, and the technique and nuances will be covered by Dr. Madhavi, who's from Tirunelveli, Arvind, who will be taking us through the journey of direct gonioscopy. Yeah, over to you.
Thank you, Dr. Prasanna, for making me a part of your instruction course. Good morning, all. So, let's start the journey. So, I'll be talking on nuances of intraoperative gonioscopy. So, this part has been already covered by Dr. Amit. So, minimally invasive glaucoma surgery is not only a bridging procedure right now, but it has given us a lot of options in the field of glaucoma surgery. So, these are essentially minimally traumatic procedures with good safety profile and good IOP lowering as well, and they target the normal physiological outflow pathway. So, right now we have a myriad of options in minimally invasive glaucoma surgery. So, whatever these options are, the first and the foremost step is the intraoperative gonioscopy and mastering the art. So, mastering the art of intraoperative gonioscopy is the stepping stone for any minimally invasive glaucoma surgery procedure. So, it really has a learning curve, and preparation is going to be the key. So, first and foremost, the surgeon should be well prepared, and before starting any intraoperative gonioscopy, prepare yourself by performing gonioscopy in clinic. Identify the structures. That is very important before going for intraoperative gonioscopy. And know your landmarks. See how much the pigmentation is in the gonioscopy while doing gonioscopy in the clinic itself. And practice after your routine phacoemulsification. That gives you confidence while doing your intraoperative gonioscopy. Next, you have to select the patients with care, patients having good neck mobility, because you have to change the patient's head position and position yourself in such a way to get a good view of the structures. And patients without head tremors and having some good amount of cooperation, and initially when you are selecting the patients, have good visibility of angle in the clinic before taking up the patient for minimally invasive glaucoma surgery procedure. So, this is how the patient and the surgeon is positioned. You have to tilt the patient's head 30 degree away from the surgeon and tilt the microscope 30 degree towards the surgeon. So, here in this video you can see that we have made some marking. I will play the video again. So, we have made some marking. So, this marking essentially helps us to adjust the microscope whenever we are performing, we are fluctuating between the routine phacoemulsification and the MIGS procedure. So, this shows the hand positioning where you have to actually rest your wrist on the head of the patient, on the forehead of the patient or the chin of the patient depending on the laterality. And note the position of the wrist, you have to actually keep the wrist away from yourself. So, next is the patient bed positioning. So, ideally if you should keep the patient in the reverse Trendelenburg position with head above the heart. So, this will help to prevent the blood reflex from the Schlemm's canal. So, a good anesthesia is also a prerequisite, because this is one of the initial cases I was doing where the anesthesia was not so adequate. So, was having a good amount of struggle while doing the GAT, because the eyeball kept on rotating where I was trying to get a good view of the structures. So, here you can see I am trying to get the forceps inside, but the eyeball keeps on rotating, and as I am trying to do, the view I am losing. So, good anesthesia is also mandatory. So, now there are a wide variety of lenses available in the market, ranging from hands-free gonio lens to floating lenses, and these lenses give a good view. And personally I use the Swan Jacob lens, but other lenses are also equally good, and this is hands-free lens, give both the hands for manipulation. So, a good high density viscoelastic is also essential for a good intraoperative gonioscopy. So, next is the docking of the lens, and we have to use a high density 1.6% sodium hyaluronate for proper docking, and be sure that you should not be pressing on the globe too much while docking. Next is the identification of the landmarks, as I told earlier. So you have to see for the scleral spur, which is the most commonly identified landmark, and look for the trabecular meshwork. And ideally we should have an en-face view, not the top-down view. So initially when you are doing, you are without rotating the microscope or tilting the patient's head, you won't be able to see any angle structures. Or if the tilt is not sufficient, there will be overlapping of the angle structures. So performing the procedure will be difficult if there is overlapping of the angle structures. So ideally the tilt should be 30 degree away, and the patient's head should be 30 degree tilted away from the surgeon, and the microscope should be tilted towards the surgeon. So you should get a proper en-face view where there is clear separation of the structures. So there are still hurdles along the way, because what we are used to is this space where we are doing the phacoemulsification. When you move to the angle, this is the space we are going to deal with, which is around 0.77 millimeter, and while we were operating on 2 to 3 millimeters. So the margin of error is going to be really less, and so the need to master gonioscopy. And also we are going to do simultaneous intra as well as extraocular manipulation. So the left hand, that is a non-dominant hand, should be gently holding the gonioscope, while the right hand is going to, or the dominant hand is going to manipulate. So undue pressure should be avoided. So another problem we are going to face is working at high magnification, which we are not used to. So instrumentation is going to be difficult when you are going to work at very high magnification. So ideally you can lift the lens, visualize where you have made the side port, or zoom out and then do the instrumentation. So next is the failure to achieve en-face view. Again, I have already told that if the tilt is not proper, or you are pressing on the globe so much, or you are not zoomed in properly or focused properly, you will fail to get the en-face view. So the way to avoid all these is avoid undue pressure, so that there won't be any corneal folds. Here the view is there, but when I am trying to push the lens down, so I am giving some undue pressure, one of the initial cases, so that is creating a lot of corneal folds, which will not, then we won't be able to see the structures rather clearly. Next is the bubble trouble, where we should not be having any bubbles in the area. Even the small bubbles can hamper while you are performing the surgery. So be sure to take out all the bubbles before starting the procedure. And blood is going to be another problem, because any minimally invasive glaucoma surgery procedure is going to cause some amount of reflex bleeding. So you have to make sure to clear the bleeding and then proceed with the procedure, rather than struggling with the visualization. And corneal haze can also hamper your view. So this is a patient post acute angle closure attack. So after goniosynechiolysis, we are doing the tenito microhook trabeculotomy, but the view is rather unclear because of the corneal haze. So beginners should not be selecting such cases, but when you are mastered, then you can go ahead with such cases. So still blurry, why? It may be either too zoomed out, or even conjunctivochalasis, bubbles and corneal edema can cause. So to summarize, with the growing popularity of the new angle procedures for the treatment of glaucoma, it is very essential to master the art of intraoperative gonioscopy. Be it any minimally invasive glaucoma surgery procedure, you have to have the art of intraoperative gonioscopy in your kit. I would like to thank my mentors, and this is my team. Thank you.
Thank you, Dr. Madhavi. We'll have Murli Ariga sir's comment on how to transition to the world of direct gonioscopy, sir, and your experiences with certain tips and tricks.
I think all what you mentioned regards to the preparation of the patient, having the patient positioning and the surgeon, the microscope, the lenses, I think all the points are well taken. I think it's very important that there is a learning curve, though it's not very steep, but you have to be patient, and whenever you want to shift, something like a paradigm shift, as Amit was pointing out, you need to do a shift from some traditional standard comfort level surgery to MIGS. You have to make this transition. You need to do all of this, and it's not very difficult, I can assure you that, and it maybe takes about 5 or 10 patients initially to get the hang of it, and thereafter if you really want to keep practicing and get your hand steady and keep doing things in different clinical situations, is to start doing it in routine cataract surgeries. Whenever you're doing routine cataract surgery, Make sure you tilt the patient, tilt your microscope, get into the angle, just touch the trabecular meshwork with a Sinski hook or something like that. So you get the hang of doing the procedure rather than straight away starting off with goniotomies and KDB blades and so on. So start it initially in all your cataract cases, get the hang of it, and then get the confidence with which lens and which procedure you're comfortable with, and then proceed with the mixed procedure. I can definitely assure you it's not a difficult process, and it's definitely worth the effort.
I have a quick question. What is the panel's experience with the Gonio Ready, which is a new device which you attach to a microscope like a biome?
Yeah.
Does that make it easier? And second question is, when it bleeds, what do you do when you're doing an intraoperative gonioscopy? Do you delay the patient? Do you try to clear it out? Because I've seen some cases also with that.
Yeah, with Gonio Ready, I think Amit will be in a better position to answer that. He's using it on a regular basis. Actually, it is pretty useful. A little expensive gadget, but pretty useful. And bleeding, yes, of course, if it is bleeding, first of all, you need to make sure that you are not on anticoagulants prior to surgery. At least 5 days you need to stop. And if it is bleeding, then you need to clear it with a very high molecular weight, dense cohesive viscoelastic. You need a good view. There is no doubt about that. And if it's bleeding too much, then, you know, I leave an air tamponade. I have not seen significant bleeding with the procedures that I do. I don't do 360 degrees. But, you know, surgery is a great leveler. Just the other week, I did an eye stent and it bled like crazy.
At the Gonio Ready, I've done almost 50 cases with it now, and I feel it's a brilliant device. The biggest advantage there is that your other hand is free, and we are, as cataract surgeons, we are used to using both the hands and using the other hand to stabilize the globe. Even if you are doing, say, an excisional goniotomy, the eye moves, and at high magnification, that slight movement also, it hampers our view. So we don't know where we are going. That plane that has to be there, that thin trabecular meshwork that we have to excise, that plane gets disrupted. So you do a bit of collateral damage, more chances of bleeding and inflammation. So with this, and the clarity also is very good. The flex mechanism that they have, it compensates for slight head movements and eye movements. If you are operating under topical anesthesia, then that also makes a big difference. No corneal folds at all. The lenses also, the clarity of the lens and the view also that we get, the magnification that we get is slightly better than the other lenses. I've used the iPrism SX, I've used the Catina, I've used the Gonio Ready, and I feel, and now Gonio Ready is my default
It has
lens.
two models, right? One
So
with the movement and one without the movement. It has two models, right? Gonio Ready has two models. One which allows a little movement,
Correct.
rotation.
There is
so that you
a
can turn
knob
around.
for gross changes in the for the gross movements, and there is the flex mechanism that compensates for the slight movements. The other thing is, other advantage is that you can use the microscope because it is attached to the microscope itself. So you can use the microscope for that fine tuning of your position, right? I feel it's a very good device.
One last very selfish question. Why are we not, you guys are all MIGS pioneers, but why are we not inventing similar models in India which will be 1/10 the prices? Because like you can have slit lamp photos coming out from copies coming out of India. You can have DSLR cameras as cameras for Ikigai.
I'm waiting for the Oro
Because
stent.
Every
early
slide
days.
says limitation is pricing. So I'm just saying.
Early days, you have Prasanna and you have so many other veteran OC members here.
No,
so
we are trying.
Just wait.
Yeah.
I'm
Yeah.
actually waiting for the Oro stent, sir.
And just to add on, Dr.
We have
Aditya.
Arvind here.
Yeah, just to add on to the direct gonioscopy, during the initial stages, the Thornton style stabilization ring. So I started with TVG lens. So with that you have a clet ring. So what happens is you get the docking mechanism and you can also move the eye with that lenses. Maybe I'll show it during my talk. So with that, what happened is I was able to get an extra more angulation during the excisional goniotomies, and it also gave a good control on the eye. Sometimes when we block the eye, when we start with the peribulbar block also, yeah, you tend to get the eye also moves along with the cluttering as a thorn way. It docks the eye along with the viscous. when you do the indirect gonioscopy and you find it difficult to remove the lens from the patient's eye, right? Similarly, with the TVG lens, no financial disclosure, it's not very economical, but it really works in a way that you can actually move the eye along with it. And sometimes when you have difficulty in visualization or other things, if you have a good left leg control, you can actually, once you keep the lens, you can move it, you can zoom, or you can find focus, and you can get the things done at a single go. Yeah, thank you, Dr. Aditya. Next, we'll move to one of the pioneers in suture gad surgery, Dr. Moideen sir from Tirunelveli, Arvind. He's going to share us his experience on threading the right way, suture gad decoded. Over to you, sir.
I have no financial disclosure for doing GAD. I think GAD is the one that is tabacular muscle is circumferentially bypassed. I have been done either a catheter, like eye-track microcatheter, or a suture. The suture we use hydroprolene, which is going to be a cost-effective mixed procedures. Just going to some case scenario. This is a 25-year-old female, journal open glaucoma, vision is 6 and 6 both eye. Pressure is 41 and right eye and left is 28, and CCT is around 490. A wide open angle and poignant cup and superior inferior nerve defect in both eyes. A maximum medication of Ganfort and Brinzox. So this is the field defect of the patient, right, left, and traditionally a corresponding OCT findings. I traditionally done trap with trap because of the younger age group with the mitomycin C. And a post-op 2 weeks is 6, very happy. At 2 months he comes with IOP of 4-minute mercury with an hypotonic maculopathy, which is seen in OCT, with developing an early cataract. So now what happens, he comes in other eye. In 3 months post-op, he comes other eye, pressure 50-45. And hypotonic maculopathy in this eye, we done a trap. So what do you want to do for the left eye? I've really been puzzled, I don't know what to do. So I was in the early stage of doing GAT. So ask yourself, you want to do GAT, yes or no? And I decided to go with the GAT. So this is the left eye GAT. So I use a 26 gauge needle. I have 2 lesser cast. I don't use MIA blade. I just go and make a goniotomy. I just depress my goniotomy site till called Slum's canal. Then I pass this 5-0 mushroom tip sutures. You can just see this sutures going along the canal. And once you go, I use a masculine forceps to put the sutures into the canal. Once you go very smoothly, you will have some resistance after 180 degree. So keep resisting, don't make the AC too shallow. Refill your chamber with a viscoelastic. I use 1.6 sodium hyaluronate to fill the anterior chamber. So after successful strokes of at least 30 to 40 strokes, you'll reach a stage where you'll have a little more resistance. So once you cross the resistance, then there's no resistance that you're going in a false passage. There has to be some resistance has to be there when you pass the gap. So once you pass 360 degree, you pull the suture, the masculine forceps. With the other hand, you just pull the suture out. So you do 360 degree gap. So after that, I just wash this viscoelastic. Then sometimes I just wait for 10 minutes. I just fill this with a 1.6 sodium hyaluronate. I just wait for 10 minutes. I go back again, wash this viscoelastic. The next time I just hydrate my wound, all the wound. I put half of fill. Then I use 1.4% sodium hyaluronate, like aerogel, to go 30% along the air bubble to make the height tighter so that you don't have an hyphema post-operatively. So what happened in the post-operatively, he had a 6-12 vision right eye with a done trap with a minus of cylinder, a left is 6 unaided, and the IOP is around 4 in the right eye and is 12 in the left eye. She asked me a question, why you don't do the same surgery for the right eye? I told her I was new. This is a classical picture of an AIOCT showing a cleft, especially in your this thing. And this is a small video just to show a cleft is passing 360 degree. Is an Cassia OCT, the DOMI, and just showing a clear-cut picture of an cleft. This is a case of a case scenario of GAT in PACG. So you know, phaco and goniosynovitis has failed to achieve a satisfied IOP level. Secondly, to dysfunction trabecular measure lead to aqueous outflow reduction. So combine phaco with IOL implantation with the goniosynovitis with GAT are found to be achieved a target IOP in a PACG. We know in India there are 50% of patients in PACG, and we need to have some procedure to control this. She comes at 15 years old, defective vision 6.6, and her IOP is 44 and 56.
I will.
And a 0.8 cup, a 0.9 cup, and PAC in all quadrants, so diagnosis on a PACG. And after doing a YAG PA, we have controlled the maximum medication. The process become 19 and 24, right and left eye respectively. You can see left is more affect on the right eye, in the visual fields. And ask you still you want to do GAT. I just go yes or no. I just decided to go on a GAT. So this is after doing a fair calcification. I use a viscode over the cornea. I don't know. I just got the thing. Then I use a hook called 10-2 micro hook, where people use for 10-2 trabeculotomy. This is a total Seneca closer. Just see, it is just. I was surprised to see angles are opening so nicely. I never thought of. I was so scared of doing anything with angle closer glaucoma. I was surprised to see these angles get opened so deeply after doing only synechiasis. Then I use my 26 needle to do goniotomy. To that pigmented trabeculum, so just put an incision over that. Then with the same needle, you depress this incision. So once you depress the incision, then you see a Slum's canal. You're exposing a Slum's canal. So once you get the Slum's canal, then you pass your mushroom tip hydropolone to the Slum's canal. Once it goes firmly, it has to go firmly. If it's going very smoothly, then you are in false passage. If you're going very tough, then you're hitting some synechia. So once you hit something very hard, then you can go from other side. So I use a Masgrave forceps. So once you go smoothly, once you cross more than 180 degree, you have some resistance will be facing. If you have some trouble in AC deformation, again you refill the AC with the sodium hyaluronate, 1.6%, make the eye little hot, AC form. Then keep pushing. After 270 degree low, so some more resistance will have. So keep persistence. And so if you're on right plane, sometimes you can see reflex blood from the other side of Slum's canal. So once you get the suture past 360 degree, they pull the suture. So once the suture is out, then you can slowly remove this 360 degree gap. So look at the IOP. I done a both eye GAT for this patient. Look at the IOP at 6 months is an apilacur and a dazolamide. The IOP is 10. So really it is, for me, works really excellent, especially angle glaucoma. If you look at the systemic analysis, especially in a PAOG, combined IOP decrease from GAT is 9.8 mm mercury, and the combined surgical success is 85%. The pool medication decrease from 1.68, and the pool reoperation rate for 20%. The pool occurrence rate of IVMAs are around 36%. So we have our own short-term data on a PACG in 70 cases, not published now. So the 59 patients underwent GAD with phacoemulsification and 11 patients underwent GAD with GSL with phacoemulsification, and interoperatively we had 7 cases of floppy area syndrome. So the IOP is around 9.64. Can you imagine in angle of glaucoma? But complications, hyphema, there are 5 cases conservatively managed. There are 2 cases still responders. So in our study, the mean IOP of 20% reduction in IOP is around 75% complete success and 25% qualified success. So just see a GAT in a post-trap case. This patient underwent trap in 2 sides, one supranasal and one supratemporal. Then I done a GAT for the faking patient and the young patient. So the process in high teens with the maximum medications, and she wants to go to Canada next week. So I told her I'll do the GAT procedure for her. Then I done the same thing. I just made a goniotomy with my 26 needle. Then I depressed my goniotomy, look for a Slum's canal. Once I achieved the Slum's canal, then I just passed my suture through this Slum's canal. So once it goes firmly, I'm 100% sure we are on the track. One more sign I see is I see a blood reflex opposite side of your goniotomy side. That means you are already into the canal. So once you go and just remove this, it slipped again. That just the pressure is around 12 on a pilocord. I always keep these patients on a pilocord for long term, at least for a year. I just keep them in a pilocord. So I was surprised even in post-trap cases, still you can do a GAT, which I thought will be difficult. To conclude, a GAT is a promising initial surgical choice for PAOG, a JOAG, and also for PACG with high safety profile. Hyphema is the most common complication we need to face. Without hyphema, no mix. Suture GAT covers 360 of the MIGS with no extra cost. I think happy patient and a happy surgeon. This is the instrument I use in no financial interest. Be simple to cut your cost. Use Swan-Jacob lenses. This can be autoclaved, used for multiple cases. We have 3 Swan-Jacob cases, Swan-Jacob lenses where we go one by one for autoclave and we'll reuse it. I use a 26-hour needle and a syringe. I use a 1.7% sodium hyalurate and a 1.4% sodium hyalurate. I use a masking forces with the retina guys used for ILM peeling. I use viscoat over the cornea for for keeping a lens. I use a low temperature cautery and I use a hydroproline. Thank you.
Thank you, sir, for enlightening us into the world of suture GAT. Dr. Madhavi, you want to add on to your experience on suture GAT? You're also another surgeon who's doing suture GAT left, right, and center.
Yes, so I think as a beginner, you have to go for other procedures before moving on to suture GAT, because suture GAT does have quite a good learning curve. So it is better to start off with bang or microhook trabeculotomy or other procedures before venturing into the procedure of suture GAT. Because sir is quite experienced, he is showing all the angle closure glaucoma cases, but it is not so easy to do suture GAT in angle closure glaucoma as he has shown in the videos.
Yeah, it always looks good when a veteran does it. And I have a question for you with regards to, let's say you, with your experience, with your, you've gone past the learning curve, if you're doing 100 suture GATs, in how many patients do you encounter difficulty? Are you not able to do 360 degrees?
Maybe 3 or 4, and most of the times it will come in the, if you go approach through the opposite side, you can get a 360 degree, I feel. Out of that, out of 100, maybe 2 incomplete. Maybe.
I think
that's fantastic. So 98% of the time you get it.
So I think if you get the angle anatomy correct, wide open angle glaucoma with nice pigmentation, I think 100% will be the canal.
And the initial 100 cases, anyway, we are going to choose open angle glaucoma. Maybe not 100, but at least 50 open angle glaucoma. Then move on to angle closure.
I'm using this to clear all my MIGS doubts. So one question: is there any benefit of leaving trabecular meshwork and not just taking the complete tissue out? Like I would say, I'm sure the drop in IOP is much more as compared to other methods of MIGS, but by destroying the entire trabecular meshwork, is there any harm we are doing long term, or is it just safe?
I think nobody knows what is working for everyone. I think best thing to do what is good for you and keep going. For us, for more than 1 year, we have good success.
No side effects.
People, whatever they say, Sinake, they say hyphema. Hyphema is there. Without hyphema, no
But
mix.
I saw you use the orogel and then minimize it.
I think we need to be, I think especially people doing trap for so many years, mix is not a big problem. Hyphema will be there, you need to take care of them.
And so you mentioned that post-trap it's more difficult to do.
Yeah, I thought the osteum will be there, it will be difficult
because I feel that's ideal post-trap. If trap fails, this is a very good option that instead of doing a
now I'm also replacing tubes with GAT.
I'll just add there, Aditya. What the question that you're asking is, are you getting more intraocular pressure reduction with ripping of 360-degree trabecular meshwork versus when you're doing segmental?
Yeah.
I think most of us are doing 90 to 100 degrees with either KDB or whoever's doing bang now, or whichever, Tanito microhook. It has been shown that the pressure reduction is not 4 times that of what is being done for only one quadrant. In fact, Dr. Tanuj Dada's group in AIMS is only doing 30 degrees. And they're finding that pressure is going down. So actually, it is not about 360 degrees. It is more about trying to target your collector channels, the maximum collector channels, which are in the infranasal area. So actually, Davinder Grover, who described GAT and suture GAT originally, now is talking about hemi-GAT rather than 360-degree GAT.
So what ma'am is trying to say is that there's not a there's no linear correlation between the degrees that you operate. So after a certain area of surgery, there is a plateau that comes, and that has to be proven again. But this is what our experience also
And
tells
what
us.
about if you do a certain sector of say KDB or Bang or whatever, and that after about say 6 months or a year, it again you still need more IOP drop. Would you go in for another mix? Has that happened yet?
I wouldn't. I would.
But why? Because you opened one collector channel, go for another collector channel. It makes sense.
Yeah, but
Theoretically.
maximum number of collector channels are there in the nasal and the inferior nasal area. So if opening up that area has not worked,
No,
opening
it
up
did
of
work,
the
and
other.
then after some time, you'd again.
See, we are still in that initial phase right now. And only further follow-ups will tell us. But reoperation rates actually are pretty low.
Okay.
They're not very high.
Thank you, Dr. Aditya, for generating a lot of interest in the discussion part of it. Yeah, and keeping the show live. So next we'll move to the magic bullet of MIGS, iStent and KDB, followed by myself. There are 3 more eminent speakers. Can I have the slides? Yeah, thank you. So I'm Dr. Prasanna Venkatesh. So I'll be taking you through the MIGS video-based deconstruction, along with a 4-dimensional live training that we have for people who are interested in it. And these are the objectives of my talk. I have divided into 6 parts. You can see that this is what I'll be covering it in this particular session. And my journey started in 2019 in the World Glaucoma Congress, where I was lucky to actually get myself trained in MIGS when I was a fellow under my mentor, Dr. Satyan sir. And it's an ongoing journey. And the goals of the MIGS and the MIGS has been extensively dealt by detail in Amit and my previous speakers. And this is one of my publications in IJO, where we'll be talking on this in this particular video-based session. And also Dr. Murli sir will be touching on gonio scrubber and SPLAT, which are something new and upcoming, along with the aqueous reduction procedures as well. So we have the patient selection criteria, which was exclusively covered. We start with mild to moderate glaucomas, and to touch on to that direct gonioscopy point, I also use a pencil marker. You can see that this is before and after. So these are some simple tricks that really help me get my practice going, where I am not assistant dependent. So I have this marking done with a pen, so that every time when I finish my phaco and send my microscope to the assistant, so that if the assistant changes also, you see that the stress levels are not very great, because he just needs to make sure the marking is connected to the one that we have drawn. So this is a very simple thing that is working well for me. And of course the head tilt of the patient, something that is very important. So no financial disclosure, but I just wanted to show this particular lens, the TVG lens. You can see that it has a clut ring here. So I found this works well in my hands. Just to add on to the point on direct gonioscopy, the Thornton style stabilization ring. You can see that this lens here, which has a lot of clut rings, especially in the initial stages when you give the peribulbar block and the eye is oriented in a different plane, right? Sometimes with the other lenses that are disposable, you don't really get an option to move the eye once you keep the lens. If you try to move the eye once you have placed the lens, you end up losing the angle. But with the Thornton style stabilization ring, I've always felt the added advantage of, you can see that sometimes I use only a simple HPMC. This is a simple HPMC, but see how the docking happens, just like an indirect gonioscopy on slit lamp, and you see how you can move the eye with the lens. This is a blocked eye. You can see that on the right hand side there is a block that has been done. But despite the block, it's actually very difficult to move a blocked eye with a direct gonioscope. But with this lens, what I've noticed is when you do advanced mixed procedures, or when you do a bang or a KDB and you want to go to the extra edge in the left or the right side, I think this lens is something that neophytes or beginners can start their gonioscopy journey, so that you'll gain more confidence as you move forward, where you start performing these handless techniques. And the reproducibility of this are excellent. This is one of my live surgery videos, which I recently got an opportunity to perform in January at Surgical Strike. Right, moving on to the excisional goniotomy, the procedural journey is the 26 gauge needle that we use for a bang for a rexus. just make sure you bend it the other way, and you go inside out approach is something that I always advocate as a right-handed surgeon. You go anti-clockwise followed by the clockwise direction. Again, as Dr. Madhavi rightly pointed out, identification of the structures is the key factor. That is how you go forward, and you can always keep following up the cleft. As you can see that this is a cleft between, I've just marked the demarcations in a bank. So we did analyze our data, and now we have more follow-up of 6 months to even 9 months and 1 year. And the success rates are quite promising even with bank 2. You can see that, this is a drop in intraocular pressure. These are my own cases, and there is a pressure reduction of one medication to 0.52. So these are some of the mild glaucomas that I started in the early journey. And of course you do have your fair share of failures, and certain observations that I have noticed in 2 of my patients are the patient's visual acuity is fine. Maybe at then we can have the discussion on this. But the 2 patients of mine in a study of around 50 to 60 eyes, I've seen some mild choroidal folds along with the microemphysema, and one of my patients did had a PAS inception, which I have not seen in a KDB case. So again, this is a KDB analysis of the same. You can see the drop in KDB is slightly more plateaued compared to the bang, at least in my hands. And the reduction of medication rate again is quite similar to 1.16 to 0.66. These are the mild glaucomas that I am talking about. And again, the failure rates are quite similar to the bang, but the complications are more controlled and more refined compared to a bang, where you can see the mean reduction in intraocular pressure. I feel KDB group shows a slight mean reduction, which is slightly better than the bang, because I feel that blade is actually more made for that. And day before yesterday, madam also covered that KDB, you get more of a complete removal of the trabecular meshwork. You don't really nick it or open it. It's more like a complete removal of the trabecular meshwork. And AGM reduction shows a similar rate, but the IOP reduction shows a slightly higher one compared to the AGM reduction. So the procedure, so this is an unedited video. I wanted to show an unedited video of the KDB procedure here. I just want you all to notice this particular thing. You can see that the field is more, a lot of having blood. When you place the lens, you can see the centrifugal distribution of the blood. So once that happens, try avoiding taking your gonio. Once you remove the gonio, again a centripetal rush takes in. So that is something you need to avoid. So what are the key points here is your left hand and your left leg. So now I am zooming in with my left leg, and I am now fine focusing again with my left leg. So now I am doing the fine focusing. So this is a 2-minute procedure once you master it. So you can see the length of the video is 2 minutes. I have not edited it, I have not fast forwarded it. Now I am zooming out. So why am I zooming out? I want to identify the main incision so that I can get my KDB blade in. And again I am zooming in. At every point you can see, I don't move my left hand. Again, this is not a Taunton stabilization ring. This is just a eye prism S that I am using. So with the disposable lenses too, once you master, just make sure once you put the direct gonioscopy, don't remove it, just have it there in situ, and then go for the excisional procedures. Your left leg has to work. If you want to move towards your left or the right, you want to find focus. So again, this is a good sign that you are seeing. So once you have started opening the trabecular meshwork, and you can see that a small amount of blood will be there, that is a good sign that the episcleral vessels are actually perfused. And if you have some difficulty, as you can see, I am having some difficulty in the clockwise movement. Just reassess yourself, don't be very quick. Just make sure you are in the right plane, and there it is, the procedure is done. It's almost completed in 1 minute 17 seconds after I did the direct gonioscopy. So this is again the completion that I wanted to show. You can always use a Helon GV Pro, no financial disclosure. Again, see how the blood is removed from the cornea. See, now the blood is on the cornea. So I am putting the Helon GV away from it so that you can see how the blood is now getting cleared from the cornea. So these are some simple tips and tricks which are very important when you are doing advanced mixed surgeries like suture gad, where you will have to have a lot of removal of blood when you are going with the procedure. And this is again another simple one for video recording. I am putting some saline on the lens. I am asking my assistant to put some saline. So what I noticed with the disposable lens are, sometimes a good video recording is hampered. When you put some saline, right, the field is again cleared and your video recording quality improves. So this is just an unedited 2-minute video that I wanted to show. So once you master the procedure, how you can really take things forward. So now we have slowly but steadily moved into some of the angles which are more oppositional angle closure. You can see these patients where the root of iris is slightly more highly inserted. But once you identify the right plane, right, you will be able to even get the fall of the iris. As Mohiddin sir was showing in his video where he used a Tanito hook to actually press down the root of iris. The same thing can be done with the KDB as well, where you can see that once you are in the right plane, opening up the trabecular meshwork can also cause the root of the iris to fall back in cases where the pigmented, the root of iris is at the level of pigmented trabecular meshwork. So it really works well. So we also shifted slowly towards moderate glaucomas and select angle closure cases, and we saw a drop in intraocular pressure of -6 from 20 to 14 and AGM reduction of -1.28, and 86% of the 42 eyes are medication free. And this is one of the novel observations that is due for publication in the next issue of Indian Journal of Ophthalmology, where we are publishing a W sign with KDB, where there is a complete removal of the trabecular meshwork, and you can see that that is not seen in a bang, which I will be showing in the subsequent slides. So in KDB versus blank, you can see that there is always leaflets that are there, which are very minimal with KDB. This is again an animation video made by me, where in bang there are always leaflets that are possible to be remnant. You can see that in the bang scenario, there will always be some amount of leaflets which may serve, you can see these leaflets, which may serve as a precursor for future PAS formation or even trabecular sclerosis. Again, this is another novel technique that I used to follow when you want to reach the more periphery. Just give a nick, and I think I learned this technique from some of my colleagues on the dais who has a lot of videos. You can always use ILM peeling forceps, then remove the trabecular meshwork which is overhanging, and you can keep it on a sponge and then demonstrate it. So then we have the iStent G1. In the iStent G1, which is now obsolete, so I'll just show what is the right implantation of this technique. It is a tangential insertion. Again, anatomical orientation is the key. So once you identify the normal plane, place the iStent in a tangential orientation, and once you are in the right plane, you can leave it. Sometimes I have seen scenarios like this where the episcleral vessels here, you can see that just adjacent to the stent, you can see how the perfusion actually starts. So you tend to have fair share of learning curve. These are some of my initial cases 2 years back, where I used to search for the trabecular meshwork. You can see that there are a lot of cheese wiring happening in attempt 1, attempt 2. So this is a learning curve that you have to endure, and you have to be patient, and you will always be able to do successfully. So these are some of the scenarios that happens in you when, again, this is one of the cases where cataract was done very well, but then when I went to the iStent, the stent was just not there. So it just dropped in the injecting cartridge. So you need to really know the magnification levels, and you need to have a good amount of wet lab training so that you will be able to manage these kind of scenarios, a drop stent in situ or outside the cartridge. So this was something that I wanted to show because these are very small. It just looks like a fingerprint where you need to really work yourself way through. Yes. So moving on to iStent inject G2 series. So in the G2 series, you can see you will more have an axial implantation where it's more automated, and you need to give a slight dimpling and place the stent, and you can see a beautiful paralimbal blanching between the two stents. Not in all cases, but once we are in the right plane, sometimes the tissue really talks with us and says that we are in the right plane and keep going forward. And you tend to have again a fair share of complications in this as well, where there was a superficial implant. You always have to reassess yourself, place the second stent first, then you'll have an opportunity to reassess, retrieve. And in the initial stages, there were not many videos, and you tend to be over anxious. I forgot to close the trocar. So these are some basics you need to keep in mind. Close your trocar and then take it out. So if you fail to close your trocar, you may again lose your stent in the corneal wound. That is what happened, but all's well ends well. I was able to recover it and then place it back in. So the data of us are coming, and it is very promising. Saiban and myself are going to publish it in the Journal of Glaucoma. It's a multicentric one, and the data is, and 91% of the patients are medication free, and the drop in AGM is 1.8 to 0.27. In iStent and in inject, it is almost 80% of them are medication free, and you can see that there is a slight plateau that we are concerned with, but let us see with more time. This is remaining for 6 months and 9 months. Let us see how we can take it forward. And there are a fair share of failures in this as well, but with more time, I've seen what patients really work, and we are taking things forward. And this is an iStent Inject W that recently came with a broader flange, where you can see that there is over implantation that is avoided. You can see the broader flange that is there in the iStent Inject W, where the more better control is noted, and it serves a much reproducible results compared to it. We have one case published with the urate Zavalia features after a stent injection. So this is one of my publications in IGO, where we did have one spike in IOP. The pigmentation was more, I think, hindsight, these are cases we can avoid, where we ended up publishing a urate Zavalia case, which was one particular complication that I wanted to bring to notice. And then this is my novel observation, my dear friends. To summarize the MIGS, this is the publication that is due in Indian Journal of Ophthalmology. Figure B is the Y sign that we are publishing with KDB, and figure C, as Mohiddin sir rightly showed, there is a remnant with the bang procedure, and you can see more of a bird beak configuration, the magnification of suture gap. Because in suture gap it is more like opening a piece of paper with a thread, right? You can see that there is more like a bird beak configuration, and the orientation of the angles. I went to Anterion because Anterion has more resolution compared to an ASOCT or a UBM, and we have come up with this. And the other topics, I think the next speakers will be talking on how to combine MIGS, which is also published by myself, where we combining MIGS is another visionary outlook I learned from Anita ma'am. And this is a metaverse that we have innovated. It is a patent protected innovation of mine. We have it with us. Dr. Pavitra, my associate, is there. People who are interested, we are always there to show you this one. We went ahead, we didn't want, the love of MIGS took us more further. Everyone was focusing on simulators for cataract. So we wanted to go ahead and make something for MIGS, because we wanted to have a more affordable and a portable and a cost-effective training module, as you can see. Why can't we do something for MIGS, so that, because you don't get to practice in a Godse, there are some similar models that are there. So we have our own holographic simulator for MIGS, where you can do n number of times the stent placement in the right plane, it turns to green, and you can go ahead and get it done. To summarize, what MIGS is, anti-VEGF is doing for retina, I think MIGS is something that is there, and it is doing something for the glaucomatologist. And these are some of the observations that I have made, and this is a personal observation and a personal take that works well in my hands. I think with more time we'll know better how each MIGS are functioning. With more data, with more randomized controlled trials and more multicentric trials, we'll be taking things forward. So thank you once again for this elite panel for consenting for this IC. I think if I am able to do it, I think everyone here who's aspiring to do MIGS, you will also be able to do. Thank you once again for the opportunity. We'll have the discussion at the end. We'll move to the next speaker, another dynamic and upcoming stalwart in MIGS, I should say, a yo stalwart, Dr. Saiban Sethi, to cover on the data and something more on MIGS and a newer perspective.
Thank you so much, Prasanna, for having me here. And so I'm going to be talking about does minimally invasive, which is what we're talking about, minimally invasive glaucoma surgery, really does it mean less risky? So this is the other side of it. So now imagine a patient, she is 33 years old now. When she came to me, she was 30. Now she had an open angle glaucoma, an advanced one in one eye, for which she underwent a trabeculectomy and clearly understood the nuances. So she was on long-term AGMs, and you can see the anterior, the ocular surface is also compromised, but has a pressure of 29 on 4 anti-glaucoma medications, but a very mild glaucoma. So now all of us who do TRABs would know that this is a case to actually avoid TRABs as much as you can, because there is a high rate of failure in such cases. So I went ahead and did a MIGS procedure in this patient, and we have a follow-up of 2 years for this patient, and the IOP is well controlled on 2 anti-glaucoma medications. So this is a long follow-up showing the success of MIGS, the avoidance of trabeculectomy, and how it has benefited the patient. Again, another case suffering from severe ocular surface side effects, and you can see how red the eye is. Again, this patient is very well controlled on the number of anti-glaucoma medications he's on, but wants a cataract surgery now. So in this case, if you do combine it with a trabeculectomy, you know again that there is a high chance of failure. And if the patient is well controlled on a few AGMs, I wouldn't really want to specifically go in for TRAB unless I'm left with no options. So now that we thankfully do have an option, the cataract surgery was combined with the MIGS surgery, and the patient already with a 9-month follow-up, you can see that the ocular surface is already feeling much better. Again, another patient, a gynecologist by profession. So she underwent trabeculectomy about a year ago for corona-induced uveitis, ended up being a steroid responder. Now 5 months through her TRAB journey, she was started on anti-glaucoma medications, out of which the only one that she tolerated was tafluprost. To her dismay, that also got discontinued. Following this, she underwent a temporal SLT, and that also started failing in 3 months, and she landed up with an IOP of about 39 millimeters of mercury. Now, to top it all up, she did not have glaucoma. She was just an ocular hypertensive. Again, doing a trabeculectomy seems trabeculectomy seems a little more aggressive in this patient. So, with MIGS, she's well controlled. I have only a 6 months follow-up, and the pressure is well maintained with no medications. So, yes, we do have advantages of minimally invasive glaucoma surgery. They preserve conjunctiva if needed in the future for more advanced disease. They also spare you from sight-threatening complications, and they do have faster recovery, and the quality of life is what every patient and even the doctor is looking for their patients. And for the sake of not having a bleb, you're spared from a lot of dreaded complications like blebitis, endophthalmitis, tube exposures, overhanging blebs. Even the TVT study says that in a 5-year follow-up, the tube group has about 43% and the trap group has about 63% rate of surgical complications post-operatively. Now, we do not have a head-to-head comparison on how it fares with trap versus MIGS, but yes, the numbers that have come out of the number of complications we find with MIGS is significantly much lesser. Also, there is no chance of hypotony because the pressure reduction in MIGS is governed by the episcleral venous back pressure, which is about 6 to 8 millimeters of mercury, and with a MIGS procedure, you're never going to get something lower than that. Also, refractive neutrality. So, all sorts of MIGS are fairly refractively neutral. So, even if you're thinking of premium IOLs or toric IOLs, these are probably better glaucoma procedures to combine with in your cases compared to trabs and tubes where you will be a little more mindful. Also, when it comes to patients on anticoagulants or antiplatelets, the TM bypass procedures, they still score over the TM stripping procedures, definitely more so with a 360-degree TM stripping procedure where the hyphema can be actually as dangerous as what you would expect with a trab. So here are a few complications. No procedure is free of complications. So these are my complications that I've seen through my course of MIGS journey. So apart from IOP spikes, intraoperative hyphema, postoperative hyphema that you see in almost all cases of MIGS, you do also have times where you get overimplanted lost stents, you get occlusions, you get malpositions, you get fallout of the stents. Also, in cases of TM stripping procedures, you have rates of peripheral anterior synechiae, you can have an eccentric pupil, and there was a case where also there was a dispersion of pigments which went behind and affected even the vitreous. Again, even with bang, because it is a less neater cut compared to KDB, the amount of pass is probably more. So you can see a broad-based pass over here. TM leaflets also. So apart from the regular complications of hyphema, IOP spikes, inflammation, CME, and peripheral anterior synechiae, which has been reported with almost all cases of MIGS in literature, there are certain specific complications which apply to certain specific techniques, like trabectome can have transient hypotony, has been seen to have Descemet's membrane injury, fibrin formation. The eye stents include, of course, the stent-related complications like malposition, occlusion. There has also been reported development of cataract, PCO, iridodialysis. Even with the TM stripping procedures, the risk of bleeding is a little higher. You can end up with cyclodialysis, iridodialysis, etc. So this is my data. This is a 12-year follow-up of 30 cases of bang that is actually out there as a poster for anyone who would like to read it. And this is the multicentric study that we were just talking about. On our initial experience with iStent and iStent Inject with and without phacoemulsification in the Indian population across all severities of glaucoma. And this was done in patients who actually needed cataract surgery or needed IOP reduction or needed medication reduction. And what we see, I'm sorry for the last minute slide which is not very clear, but what we do see is that compared to iStent first generation, iStent inject definitely brings about a much higher reduction in IOP and AGM reduction. There was about 50% reduction in intraocular pressure using iStent injects, and also a drop of anti-glaucoma medications from close to 3 to close to 1.4. And this proved to be statistically significant. So I think from this study that we did, I can conclude that iStent is a good tool to reduce your medication burden. It may not really reduce the amount of intraocular pressure that you would be expecting. Thank you.
I think next we'll call Dr. Pandam Pathakare to your talk. We have less time.
Thanks, Saiban. That was bang on time. Yeah. So I'm going to talk about ECP and a concept, the inception of combined MIGS, and not combining two outflow MIGS, but just wait for it. So, you've heard a lot about MIGS. It can be categorized in several ways. What I like to do is step back a little and think about it in a very broad perspective. What is that? You look at drainage, aqueous drainage outflow procedures, and you look at aqueous drainage reduction or inflow, reducing inflow procedures. So no matter what it is, they're all utilizing MIGS, are utilizing natural physiological pathways. And these procedures that I'm going to talk about are all internal and require an open angle except for ECP. So MIGS, like anti-glaucoma medication, is utilizing natural physiological pathways, the ciliary body, the trabecular meshwork, and the suprachoroidal pathway. Unlike TRAB, which creates a unnatural filtration on the surface of the eye. So inflow MIGS is wholly ab-internal. It is delivered with endoscopic cyclophotocoagulation. It's a diode laser. It was first described in 1992. It's the original MIGS. It's ab-internal, can be combined with cataract surgery, and the advantage is that it can be used irrespective of angle status. So therefore, its indications are very broad. You can use it in any type of glaucoma, and the power, the delivery of power is way less than the transscleral variety. However, the disadvantage as opposed to transscleral is that it requires a sterile environment. Standalone procedure, entry, you can do it. Entry has to be corneal or pars plana. Pars plana requires vitrectomy, limited vitrectomy. Complications, that's the sum total I have had. Hypotony does not feature there. So the setup is fairly simple. It's a machine, E2 machine, which has endoscope, illuminator, and laser. I record all my cases, and you look at the screen and operate, and I use a 19-gauge curved probe. So just show you a video very briefly. After IOL is in the bag, I bump up the sulcus. This is a case of acute angle closure. You can see iris ischemia, sphincter atrophy, in this case, a very floppy iris and lots of pigment dispersion. So what I do is I first put OVD and endoscope in the AC and look at the angle. And what you see there is only pigmented Schwab's line. Then what I do is I use a little bit of OVD in the sulcus, bump up the sulcus between iris and anterior capsule, and then that's the endoscope in the sulcus. You visualize the ciliary processes. I start with a phaco wound. You can only do about 180, maximum 210. The superior one is completely spared. And you laser the ciliary processes. The wattage is only up to 500 milliwatts compared to 2000 that you might be doing with TSCPC. You definitely want to avoid POPs, and as soon as you get that, you reduce the power. That is what helps in controlling all the complications like fibrin, like CME. And once you have done it, what I do is, you can see this is the view through the microscope, and that was the view through the endoscope. So OVD and endoscope is in the AC again, and I don't know if you can appreciate it now. You can see a much broader angle visible, a trabecular meshwork which is very pigmented, and so is the scleral spur. But the angle opens up, right? Following this, have a look at a few more cases where post-phaco you don't see an open angle, but after you've done the ECP, you can see a open angle. Same in this case, albeit with a lot of pigmentation. So I have published ECP, especially in angle closure. I do believe it works very well in angle closure. And 15 months follow-up, you can see fairly good outcomes with complete surgical success rate of 75%. 75, 3 out of 4 individuals, patients are off medication, 15 months. ECP in POAG, less number of complete success, but nonetheless, pretty successful, 95%. And reoperation rate, pretty low, less than 10% is good. You may ask, why phaco ECP in angle closure and why not phaco alone? I will tell you that the amount of reduction of IOP is double that in phaco ECP, and the reduction in medication is double that in phaco ECP when you compare it to phaco alone. So I actually prefer phaco ECP. The ab internal outflow MIGS, mostly targeting the trabecular meshwork or the suprachoroidal space. We don't have any devices for suprachoroidal space, but we do have for trabecular meshwork. I don't want to go into these details. They have all been covered before. But the ab internal outflow MIGS that I do are generally 2. Bang was something I used to do. Even iStent implantation you have seen, but I just briefly show an iStent W in pigment dispersion syndrome, where you inject the first W. I always go inferior first, so that if it bleeds, it does not obscure my view for the second one. And then I inject the second one. And once the procedure is done, you can see nice regurgitation through the, this is how it should be seen post-operatively, gonioscopic view. Then KDB, again, you've seen many, many videos, but again, I tend to use it quite a bit in angle closure. Trabecular meshwork, not very visible, but as I proceed, you can see the iris falling down and the channel opening up. And how do I know? I have precisely excised, because I always gather what I have taken out, and I demonstrate it on a sponge, as you see there. And you can also, of course, do bang. This is something I am doing less and less. You can always see a clear cleft or unroofed Schlemm's canal. This has a little bit of pigmentation. So with the outflow MIGS complications, again, Sahiban has covered. We all talk about IOP spike, it's transient. We all talk about hyphema, that too is generally transient. It can be very high in GAT, up to 70% in Hughes paper. DM detachment can occur with iStents. You can have over implantation, you can have blockage, you can have PAS formation, you can have reoperation or failure rates. Compare that to the real huge list of sight-threatening complications that we see with TRAB. I think it's a no-brainer. So when you look at the results of BANG, KDB Glide, and iStent Inject in mild to moderates, you can see that there is at least about 17 to 20% reduction of pressure, more so with KDB, and definite reduction of anti-glaucoma medication. So what if we can combine MIGS to reduce inflow and increase outflow in advanced glaucoma? Will the IOP be controlled? Can you reduce AGM? All MIGS are known to be overwhelmingly safe. So combination of these should not really be causing any issues. Combination of inflow and outflow I do for an additive synergistic effect, where I use iStent KDB for outflow and ECP for inflow. I just move on, just showing you a few examples. This is a doctor. He, POAG with cataract, quite advanced, fixation involved. He's a doctor. He's progressing. He doesn't want any more medication. So what do? I do a combined inflow-outflow mix, and I find that his pressure, vision, and medication, all very satisfactory. Yet another patient, very young, 51-year-old, but thankfully his other eye is fine. He has very advanced glaucoma. You can see he's 22 on 3 drugs and does not want anything else because he thinks it's useless. But you do a combined mix, his pressure is 11, vision 6.6, with no medication. And yet another young patient, 55-year-old, angle closure, 19 on 3 drugs. He's a known asthmatic, and this is all the field that he managed with stimulus 5 in his only seeing eye. So I did a combined mix, and you can see I have left him on pilocarpine deliberately because he's angle closure and he cannot come for follow-up. So when we look at the data, combined data, you can see that from an IOP of almost 19.5, it has come down to 12.5. What more do you want in advanced glaucoma with a reduction in medication from above 3 to 1? So and no serious complications. None of the patients have actually lost vision. So whereas single mix procedures are indicated in mild to moderate disease, you can successfully combine inflow and outflow mix to do it in cases, advanced cases where TRAB has also failed. It's overwhelmingly safe and particularly useful when there is anti-glaucoma medication related issues. I feel it is non-inferior to TRAB. I don't get the same complications, and I definitely don't create a bleb. Combined mix, still, I will say, spares the conjunctiva. So if you still want or need to do a TRAB in future, you can do it. Of course, long-term results are awaited, and an RCT is ideal. It is very patient-centric. We all know that, but cost may be a limiting factor. Thank you very much for a patient listening.
Thanks, Vinita. I will call upon Murali to talk on micropulse and newer goniotomy procedures.
Thank you, Vaidya. Yeah, good morning, and I think there's no single definite accepted single definition of MIGS. And we all know what MIGS means is that it's basically a procedure which is minimally invasive, relatively, fair IOP lowering efficacy, and probably safer than the trabeculectomies and the glaucoma drainage devices, and can be combined with cataract surgery. We have the outflow devices, we have the inflow kind of drugs, we have the suprachoroidal shunts, and we have the destructive procedures, cyclophotocoagulation. So what about the procedures targeting outflow? I think we've just seen many of them, and we've also seen the ab internal procedures without the implant. And my current MIGS, most of them are reusable instruments and relatively low cost, but we have a large community patient background, so we do quite a bit of the reusable instruments. My favorite in particular to start with has been the Tanito micro hook, and I use it extensively in combination with cataract surgery. As you can see in the picture, you see the tip of the instrument, and you do have a straight hook, and you also have a left and a right hook. I have about 5 or 6 sets of these instruments which I got a few years ago, and I still continue to use them. And they're very simple procedures, provided you understand the way you look into the angle and do the procedures. So Tanito micro hook can be done mostly in the nasal angle, can also be done in the temporal side if you really want to do more of the goniotomy, trabeculotomy with the hook. If you want to look at the relative sizes of the instruments which are available, you look at the one on the top is the Tanito, the one below is the KDB, and then you also have the other instruments in relative size. So it's a very small instrument and a very elegant instrument, and even though it's pretty expensive currently, it's supposed to be coming into India very shortly. Extensive publications available now, both in ophthalmology, glaucoma, as well as IOS, and our own publications on the way. Our short-term results of 2 years and 3 years with the Tanito micro hook, with varying degrees of angle being treated with this. And I'll just show you a short video of how a Tanito can be done, and you can actually offer the benefit of an EDOF lens, offer the benefit of doing a toric lens, and of course offer the benefit of doing the angle surgery with the Tanito and all the MIGS procedures. And this is something which we don't highlight to patients, that Of course, we don't do trifocals and we don't do multifocals in these patients, but I think you can definitely do torics and you can definitely do EDOF lenses. And routine phaco is done. Following that, you can speed up a little bit. And after the lens is implanted, you can see the lens is Indian kind of an EDOF toric lens. You see the serrations on the to have stability of the lens. And once the toric is implanted, you can actually go ahead and see the angle. Put in the visco is removed, then you replace with thicker and denser hyaluronate. And this is my favorite, the ocular lens, which I use most often, the handheld lens. I also use the Catina. And it's a very clean surgery. In this particular case, there was hardly any bleeding at all. You can see the tanito clearly going through the trabecular mesh. I initially started with 100 degrees. Now I have gone to 90. And with the Espilat, I'll show you a short video of the Espilat also. The Espilat, I do much less than that. I'll skip this video because there's another video of the tanito. And this is the Espilat. This is another favorite instrument of mine. This is somewhat like the KDB. Except as you can see the instrument, it has got a foot plate, it's got a flat wedge-like device, and it's similar to the tanito, except that you can actually strip off the trabecular meshwork on either side and leave it as a heap on either side. It won't really cut through and remove it like the way Vanita was showing. So we'll heap it up on both sides, and I've now started doing 60 degrees of the Espilat, and it works as good as the 90 or 110 degree tanito. So this is called the juxtaclinicular slider. It's not called an Espilat hook, it's called a juxtaclinicular slider. A very elegant instrument, and the manufacturer, you can talk to him and email him. He actually gives you a lot of feedback, and there's a lot of, it's a very simple reusable instrument, unlike the bang kind of blades, the needles which we need to bend. So this is Espilat for you. And moving on to another very interesting instrument which I procured recently. This is called the gonio scrubber. I think many of you might have heard of it, but I actually used it in certain patients, particularly with extensive pigmentation of the angle. You can actually go in and scrub the angle. This is a Mori lens. This is somebody else's video, so I'm going to speed up a little bit in the interest of time. And this is a Mori direct surgical gonio lens, and you see the angle being seen, and there's actually a micro brush in which you go into the angle deep in the chamber and simply brush out the pigmented, it's like you're cleaning and sweeping out the debris and pseudo exfoliation and pigmentation material. You can probably, of course, combine this with a goniotomy as well. And you can, this is a very elegant procedure. I have now asked the company to give us a smaller version of the gonio scrubber. So you can actually do a gonio synovialisis, do a scrub, and then put in a goniotomy and do whatever else you like with the angle. So moving on again, our diode procedures, are they really mixed? I think Vanita answered that quite well. And then I was doing initially with the continuous wave diode. Now I have moved on to the micropulse. The micropulse is, we had the older probe and we have the new probe now. And the older probe was excellent, and we used to, this is, I think, most of you have seen these procedures. I'm not going to show you the complete video. And this is how it is done. It's just a sweeping movement in the, on the ciliary body, and sometimes you will have difficulty in seeing the ciliary processes. So what you do is you transilluminate and try to get to visualize the angle well. And a comparison of the different probes available with my console and instrument. You have the G probe, you have the G probe illuminate, and you have the MP3 probe. You have 3 different probes. The G probe illuminate is a particular favorite of mine because it really helps you see where you're actually treating. And the MP3 probe was what is the standard till now. You of course have the newer probe called the Bunny probe. The Bunny probe is not so effective, and we have asked the company to give us back the old probe. So we now got back the old probe since last week. The old probe is actually back in action now. This is the first Indian publication of ours on the micropulse transscleral diode with the older probe, and it is a fair 20 to 30% reduction in IOP, and many times have combined it with anti-VEGF injections and with cataract surgery as well. Some of the patients in whom I have been doing the micropulse in seeing eyes, post-PACG, uncontrolled with the ACPI and not willing for surgery, post-AGV, post-TRAB, medication, severe medication intolerance, and even after the Boston K-Pro and so on. Some of the examples. Advantages: safe and effective alternative to the continuous diode, can be used in moderate advanced glaucomas and those with vision potential as well. Reduces the need for topical medication definitely, but you may not be able to completely take off all the medication. There are some problems with cost and logistics and inflammation, mild inflammation. I have not encountered any hypertony with the micropulse CPC so far in about our series of about 180 to 200 patients.
pupil dilatation is possible in the initial learning curve when you don't position it so well. And of course, don't treat areas of thin sclera where there are blood clots and recent surgeries and so on. So in my practice, where do I position my kind of MIGS in our practice scenario? Is that in the milder to moderate glaucomas, we do offer SLTs and the MIGS and maybe combine it with cataract surgery in mild to moderate. And now I have started offering this combined kind of MIGS, and I do a micropulse along with a MIGS procedure, which is what she was talking about, as an endo-CP, ECP with MIGS procedures. And of course, the advanced glaucomas, you don't have much choice but to do a trabeculectomy combining with cataract surgery and maybe a glaucoma drainage device. Thank you all for your attention. I think we are short on time, and I think the next IC team is waiting. I think we'll have to move on. I thank the speakers and thank all of you for your participation.
Ma'am, we'll take it at the end or outside. Sir is down there. Yeah. Apologies to the next IC team for overshooting by 6 to 7 minutes. Really apologies. And sorry, sir, for pushing you also for the quick completion. So thank you once again.